in the last 20 years of my life, in part, professionally, have been devoted to improving the outcome of what we all do together every day. And I care a lot because, one day, Leah and Rachel, they're 24 now, so let's say 10 years from now, they're 34, married, off the family payroll. They decide to move to Grand Rapids, and they'd like a doctor in a hospital. Maybe they'll choose Spectrum. But let me give you some insight about these young people, and I'm sure your kids are no different. So, how many Facebook users are there in the world today? 500 million. 500 million. Raise your hand if you have your own Facebook page. Okay, I would say probably a sixth of the audience. Now, they have Facebook pages I have never seen, of course. They don't allow me to friend them, but that's another challenge altogether. The average Facebook user posts 72 pieces of unique information per month. One more time, 72 pieces of unique information per month, which in my way of thinking is they're not doing much of anything else. So your Facebook page, your level of accountability, your level of transparency, my ability to turn the lights on when we get excited. Heart rate goes down. It's good that I'm in good shape, because this is like a cardiac stress test up here. So let's talk about the future. So Leah and Rachel move to Grand Rapids. They want to come to Spectrum. They're going to demand that you do email with them, that they can schedule everything online. Who are you and I kidding? To young people who grew up, Jake is 19. When he was 14, even 15 years old, he turned to Esther and me. He said, "Daddy, when you and Mom met, what was your email address?" The arithmetic for that doesn't work out, Because why? They don't know any other world. When you have all of the information that the world has to offer literally at your fingertips when you're 15 years old, do you think they're going to settle for, oh, no, we don't do pap smears every third Wednesday? And you got to have separate appointments and, sharing a medical record? No, we don't do that here. So I know from your Strategic Vision 2020, you're working hard to coordinate all of that. So are we. I hope I live to see it in my practice lifetime. I really hope I do, and I know many of you feel similarly. So these are some of the challenges we've got. So how are we going to meet this leadership challenge? Well, let's talk about doctors, then we'll talk about board members, then we'll quit. So, doctor leadership, some people even consider that to be an oxymoron. Doctors are wonderful technicians. We're an incredibly smart group of type A personalities who get good grades. To most of us, golf is a team sport. Medical staff leadership in most places that I've visited in the last 20 years goes like this. You missed the last 3 executive committee meetings. Wonderful. You're the incoming president. Or better yet, now in all seriousness, better yet, well, we're going to have the quality committee of the medical staff. That's going to meet every month on Tuesday at 5 o'clock. So heaven forbid we can't interfere with OR or office hours. And in that 1 hour per month, we're going to deal with everything we got to deal with regard to the quality and safety agenda. Right? Dead wrong. Can't be. Why don't you just credential me to do brain surgery as a primary care internist? Because it's the same level of arrogance, and you know exactly what I'm talking about, that goes into that decision. Sure, one Tuesday at 5 o'clock, that ought to lick it. So one of my heroes, Brent James, who made it the front page of the New York Times Magazine this past winter, he's all about physician leadership, but physician leadership how? By measuring and evaluating what we do every day, by a difficult look in the mirror to see who we really are, and then a willingness to work together in a team to share decision-making and learn from one another. Yikes. I'm exhausted just thinking about it. And I'm sure you are too. Because that's not the culture of what our current practice is all about. This is where the rubber really meets the road. So what are physicians as leaders? Well, here's the 1998 paper in Annals of Internal Medicine by Jim Reinerston. It's as true today as it was then. We won't go through all of these, but number 3, leadership is not victimhood, meaning you miss the meeting, you're in charge. And you could read the others. Or how about leaders are not daunted by the loudest negative voice? You know the old gag, right? It was a close vote of the medical staff, a tie, 1,000 to 1. Because the loudest negative voice prevailed. Or, it's like the Marx Brothers. You remember Marx Brothers? Whatever it is, I'm against it. That's medical staff leadership. How do you expect medical staffs to organize and create leadership without training doctors in the business of leadership? That's nuts. So, moving forward, a board-level decision is physician leadership training. So you've got a great base, John Burns, David Dull, the whole team. You're well on your journey. This is my 4th visit to Spectrum. I've had the privilege of working with your medical leaders twice, off-site, a whole day at a time. So I know you get it. But believe me, colleagues across the country, the whole notion of physician leadership to tackle the real issues of transparency and accountability, we're still sort of trying to sort that out. And you and I know just how hard that really is. So, from a board perspective, let's skip to that. What do we know? Well, we know moving forward, where we were almost an hour ago when I got up here, we know that the board is ultimately responsible, bears the fiduciary responsibility for quality and safety. Not you, not me, not Rick, the board. That's a hairy thought. So what can we do to help the board? Well, it's a whole developing literature. We have our whole textbook on governance for quality out in the front. I didn't come here to sell books, but that'd be wonderful too. So what do we know about engaging the board? Why today is this so important? Well, you've all heard about getting the boards on board, and here's the cover of Trustee Magazine, Leading to Safety, and you may appreciate that bond ratings may be directly linked to your clinical outcome. So now we've got CEOs and CFOs and COOs all energized about quality because they know that Wall Street, when you go to float that bond to build your new gorgeous building, Wall Street's going to say to Rick, well, what about those clinical outcomes? How are you doing on those medical error rates? We've been reading all about you. So that's a powerful way to connect the dots in terms of where we want to go, the board's responsibility. Let me get a little bit more tactical with you. The sorry truth is that 5,000 community hospitals in our great country, half of them don't even have a board committee on quality. How could that be? Ashish Jha and Arnie Epstein a year ago in Health Affairs, in their national survey, half of America's community hospitals didn't even put quality in the top 3 responsibilities that they have. You better believe they put building buildings right up there. Now, there ain't anything wrong with building a new building, but your number 1 responsibility, I would say, is what are we doing here? What's our principal business that we're in? So this idea of not on board is pretty scary. So how might you get the board on board? Well, not rocket science. Put this agenda out there every single time. I know an organization is committed to quality when at the board meeting, the board quality committee gives its report before the board finance committee. That's the acid test. And if the CEO or the chairperson of the board, better yet, spends more of his or her time personally learning about quality rather than the fundraiser next week. Now, I'm not poking fun. I'm giving you the straight story here. That's the indicator we use to get the sense that an organization is committed to the quality agenda. So, number 4 on the list is my favorite, linking executive compensation to quality and safety improvements. You've never seen non-clinician hospital leaders more interested in clinical outcomes than when you connect their pocketbook to the outcome. No outcome, no income at the individual executive level. Pretty scary. Works like a charm. 10 years I served on the board of trustees of Catholic Healthcare Partners, so the nation's 10th largest system, 35 hospitals, 58,000 employees, 7 states, you get the idea. Their headquarters in Cincinnati. So 10 years, 6 times a year, 60 trips to Cincinnati to make this work. Now, I like Cincinnati, but that's a lot of trips to Cincinnati. So in the last 5 years of my tenure, we did number 4. We took all 35 non-physician hospital leaders and we connected a third of their comp to the quality and safety outcomes that the system agreed to. Did we move the needle? You bet. Did we improve quality? Absolutely. Did we reduce unexplained variation? Absolutely. All the evidence, we published it to prove it. So I think the board needs to seriously think about these kinds of issues to get it on the agenda, and I'll wrap up the board's responsibility. I have 1 or 2 other ideas, a little out there. Forget one. How about number 2? So I want to read in the Grand Rapids Business Journal